Medical education in 19th and early 20th century America was built upon the apprentice system. Future physicians, nearly all men, worked under and learned from practicing physicians. Medical schools were often money-making enterprises and primarily used lectures without patient contact or laboratory experiences. That changed with the introduction of the European model of science-based medical education, hospital-based clinical rotations, and a 4-year education model. The 1910 Flexner Report formalized these standards, which soon became universal for medical education in the United States, in what came to be called the Flexner era of U.S. medicine. This era extended into the 1980s, and at some institutions into the 2000s. It led to the growth and dominance of specialties and specialists within particular medical fields. Specific changes have occurred in the last 2 decades at all stages of medical education, and new proposals for change continue to be formally reviewed and implemented. These can be outlined starting with the pre-med college years and continuing through residency and fellowship training. Select the image to learn more.
Pre-medical majors. Pre-medical training in the Flexner era was largely restricted to majors in the physical and biological sciences, plus specific social sciences such as psychology. Beginning in the early 1990s, medical schools encouraged a wider range of majors, while usually retaining biology, chemistry, and physics courses as prerequisites. Mcat Revisions. The Comprehensive Review of the Medical College Admissions Test, or MCAT, has resulted in changes including a new section emphasizing the behavioral and social sciences to parallel the section emphasizing the physical and biological sciences. A framework known as Scientific Inquiry and Reasoning Skills will incorporate basic research methods and statistics into each of the content examinations. Medical school admissions. Admissions to medical school was dominated by white males throughout the Flexner era. In the last 20 to 30 years, the percentage of women applicants has increased steadily. Today, the majority of medical students at many institutions are females. Likewise, the increase in minority applicants has paralleled the changes occurring in other aspects of U.S. education and society. Problem-based learning. The first 2 years of medical school in the Flexner era were dominated by lectures and laboratories. Basic sciences were the focus, with little or no patient contact. An important change in the last 2 decades includes widespread use of problem-based learning, or PBL. PBL is characterized by small group, student-initiated learning centered on cases or patient-oriented problems. New curricula in medical education, including evidence-based medicine, interviewing skills, and ethics, have become a standard part of coursework. A new simulated patient interview and physical examination are now a part of the certifying examination process. Electives. Changes in the 3rd and 4th year of medical school began in the 1960s, the era of student activism. Since then, the 4th year of medical school has been dominated by electives. 4th year students may choose formal courses, elective clinical experiences, or a wide array of other options. These usually include options for laboratory or clinical research, international experiences, and clinical rotations at other institutions, often called audition rotations, designed to increase a graduate's potential for selection as a resident. Range of experiences. The growing trend of patient treatment outside of the traditional hospital setting has increased the range of types and locations of clinical experiences available. Most medical schools now require primary care experiences along with traditional specialty rotations. Residency training. Residency training has paralleled the changes in medical school, with greater outpatient and less inpatient or hospital-based education. Fellowship training beyond residency is now a routine part of the process of specialization. The general move towards more and more specialization has led to longer postgraduate training. The rigors of residency training remain, but limits have now been placed on it by the Residency Review Committees, or RRCs, which govern graduate medical education. An average of 80 hours per week is now the maximum standard for residents.